Hello everyone, so today I'm going to be talking about whether serotonin impacts depression, mainly by discussing whether antidepressants are effective medications to treat depression. Overall, this idea that serotonin is very important in explaining depression comes from the 50s, when a drug which was being used to treat tuberculosis actually rendered some interesting effects. So this drug called Iproniazid did not render much effect in terms of treating tuberculosis, but the subjects which were being treated with it showed improvements in mood. And so a side effect of this treatment was actually that these doctors noticed that there were no improvements in their lung infections, but patients were feeling better, their mood was better. And so since then, since the 50s and 60s, the idea that serotonin can explain what depression is became very popular. In the 90s, this also became even more prominent given the advent of Prozac. And so this hypothesis about serotonin being the main player in explaining depression became far too popular. The problem is that these days, given how we have developed in terms of systems neuroscience and our overall intuition of the brain and understanding the complexity that involves the regulation of all of these different circuits, is that it became too simplistic to just explain depression in terms of a neurochemical imbalance, which simply is focused around serotonin. And so with this video, I want to go into some of the studies we have these days that try to find out if there is some good reason or good evidence for us to see serotonin as a good parameter for explaining depression. So serotonin is a neurotransmitter which is used in neuronal signaling. It is synthesized from a precursor amino acid called tryptophan. And a lot of studies that have looked at the impact of serotonin in terms of depression have looked at plasma levels of tryptophan. Serotonin can be measured through urine, blood, or cerebrospinal fluid. The latter is the preferable mode of investigation because it most likely will give you a better idea of serotonin concentration in the brain. But of course, given how invasive it is, most studies do not use those levels. Which stands for 5-hydroxyindoleacetic. And so we have different methods of going about this question. We can study the levels of 5-HIAA. We can look at levels of tryptophan, the precursor amino acid from which serotonin is synthesized. We can look at receptor activity of these serotonin receptors. Most studies have looked at 5-HT1A. And so we can see if there are any abnormalities in the activities of these receptors. We can also look at the serotonin transporter activity. We can see if there is some level of upregulation in these transporters. And we can also look at whether there are genetic abnormalities in the serotonin transporter gene. Out of all of these methods and questions, one of the only aspects which has some robustness in terms of findings has been depleted levels of tryptophan. And it's important to say these levels of tryptophan being plasma levels. And it is important to mention that these lowered plasma levels of tryptophan have been observed in patients with severe forms of depression. And some studies have also looked at using dietary methods to reduce the levels of tryptophan. And what they have noticed is that reducing tryptophan levels in healthy subjects did not render any effect on mood. But if you were to reduce those same tryptophan levels in patients who had some history of depression and that were away from pharmacological treatment, lowering those same methods of tryptophan in these patients with a history of depression did result in significant negative effects on mood. And so what we can comment from this is that clearly serotonin, tryptophan is not the only reason for depression. Actually, it might not even be a reason at all. It might be so secondary to this whole neuronal circuitry game that the effects that increasing tryptophan and consequently increasing serotonin concentrations in the synaptic cleft may not be that relevant at all, and there might be indirect effects on this. It is also interesting to mention that a lot of these days we hear about the potentials of psychedelic drugs such as psilocybin, LSD, in terms of treating depression. And you might be asking me, well, these drugs such as LSD, psilocybin, they are serotonergic, so they act on serotonin receptors, mainly 5-HT2A, and that seems to be one of the ways to neurophysiologically identify psychedelics. And so psilocybin is a 5-HT2A agonist, and psilocybin seems to be a potentially very effective tool in terms of dealing with major depression, dealing with, clinical levels of depression. And so it might seem a little bit confusing on how, we have two drugs that have an influence on serotonin. And so it might be confusing that we have two drugs that have an effect on serotonin functioning, and yet for SSRIs, we are saying that they are perhaps not good tools for depression, and there is some data that can substantiate that claim, in the sense that a lot of people with depression are given SSRIs, which are serotonin selective re-uptake inhibitors, which means that they prevent the re-uptake of serotonin, which increases the concentration of serotonin in the synapse. And so, to be true to the matter, we must acknowledge that we still do not know very well how the serotonin system works. We have far better models to explain how dopamine works, how dopamine is very important in terms of signaling prediction error. But when it comes to serotonin, we are a little bit far behind. So we still do not have a lot of models, concrete models, that can allow us to fully state how serotonin modulates all of this. By having a regulator of such inflammation, it might be, a good way to neurophysiologically explain part of the effects that psychedelics have on mitigating depression. When it comes to SSRIs in some animal studies, increased cell proliferation in the hippocampal area has been accounted for. We have some studies that potentially point to a neuroplastic mechanism with SSRI administration, with the promotion of proteins such as brain-derived neurotrophic factor. And so this could be partially one of the reasons why SSRIs work for some people in decreasing depression and improving mood. It's also important to state that up to now we have identified 14 different receptors for serotonin, and most of them haven't really been studied. So there is a possibility that the effect of serotonin on depression is way beyond the mechanisms that we have studied so far, and that by modulating serotonin levels, you're actually modulating other subsystems. And so there might, like I said before, there might be an indirect effect which isn't being accounted for, but supersedes just, of course, the effect of serotonin, because as we know, it makes absolutely no sense that such a complex disorder such as depression could just be accounted for by the regulation of one neurotransmitter. Given how interrelated the brain is and how messy biology is, it would be very weird for that to just be, the answer. When it comes to depression, it's also important to say that some findings state that SSRIs work better on certain types of depression. So when you have a depression which is mostly characterized by anxiety, then SSRIs seem to have a more potent effect than if you're looking at a depression which is mostly characterized by anhedonia, so the absence of pleasure. And so for different types of depression, it seems that SSRIs could work better or worse. And this is important to state because not all depression is the same. We have different types of depression, and so it makes a lot of sense that mechanistically you would have these drugs have a horizon of efficacy depending on what subtype of depression they are being administered to. That is why these days, a lot of times when you have anxiety disorders, panic disorder, when you have OCD, the golden standard pharmacologically speaking tends to be SSRIs. there is a good efficacy. The efficacy of SSRIs for obsessive compulsive disorder is far greater than for depression-related disorders. And so a lot of times these days, for anxiety, that is the main go-to pharmacological intervention. And this is why in the future we will probably have to rebrand some of these names, because maybe antidepressant isn't perhaps the best name to explain the effects of SSRIs. The same could be said about antipsychotics, given how they have more effects than just in terms of being, in terms of dealing with psychotic symptoms. Atypical antipsychotics have been used as augmentation therapies for treatment-resistant depression, so they are not just about being antipsychotic. They can also be used as mood stabilizers in bipolar disorder. Some researchers have pointed that SSRIs could work on depression through changing how we appraise the valence of information. And so what SSRIs can essentially do is that they may take a little bit of the intensity or of negative events. And so by kind of providing you with a more neutral perception of a certain problem, you can mitigate some level of depression. And like I mentioned before, given the efficacy of SSRIs for anxiety, and given how anxiety is also very prevalent in depression, if you are able to optimize one of these dimensions, then it is likely that your mood would also increase, of course. One of the pharmacological therapies also used for depression right now is ketamine. Ketamine has an inhibitory effect on the NMDA receptor, which is a receptor for glutamate. Glutamate is the main excitatory neurotransmitter in the brain. Given how prevalent glutamate is, it is still hard to pinpoint how this interaction, how specific the modulation of glutamate receptors impacts depression. So overall, what these findings point to, and my main message with this, is that serotonin may play a role indirectly through mechanisms that we aren't truly aware of right now in terms of mitigating depression, and that modulating serotonin may be more efficient for certain types of depression. A lot of these studies did not study bipolar depression. And so there is still a lot to know in terms of the different phenotypes of depression. I also would like to mention that there are new therapies being developed for depression. We have the case of psychedelic science, which is coming back. It's increasing, and a lot of progress is being done there. We have ketamine, which is already legal in various countries in the cases of treatment-resistant depression. In certain cases, electroconvulsive therapy is also used for more severe cases. But overall, the main message with this video is that biology is far too complex to just use one neurotransmitter as being the explanatory variable for depression. And so we need to be aware about the complexity and the different mechanisms of action that may be behind depression. And one of the issues of easily adopting a certain version or a certain explanation for depression, such as the serotonin hypothesis, is that limits a lot of the research. And so you have a lot of people which are just studying serotonin, they're just focused on that variable, and we are neglecting other pathways which could be involved. And so hopefully you found this video informative, and let me know if you want me to go even deeper in this topic and if you found this useful. Thank you.